Good morning and welcome to the first ICS Regional Educational Course. And I'd like to introduce the General Secretary of the International Continence Society, Dr. Sharif Murad from Cairo, to present the introduction.
Thank you. So good morning, ladies and gentlemen. I want to welcome you for the first International Continence Society regional meeting that is taking place here in Phoenix. And as you understand that this is our first meeting, and we started here in North America. This meeting will be alternating yearly between North America and Europe. And I have to say that we didn't have enough time for making more preparation for this meeting, but I'm sure that the next ones will be more popular, and we'll have double or triple this number, I know. To start with, can I ask you who in the whole is urologist here today? Oh, many. And gynecologist? Not bad. Next time will be better. Nurses? Physios? Okay, so this is a multidisciplinary meeting as usual. I'm very happy that we have the four specialties represented here again. I wish that you will enjoy the meeting and you will get a very good outcome tomorrow after we finish. And we are waiting for your feedback. Thank you very much. And I think we have to start now.
Thank you, Sharif. Thank you, Sharif. And I'm Chris Payne, a urologist from San Jose, and I'll be directing the meeting, and we're going to start, of course, with the required announcements. First and foremost, a thank you to the industry sponsors who have made the event possible. Really are very appreciative. The exhibit hall is out the door to the left in the next room, so immediately adjacent here, and that's where the coffee breaks will be held. So when we have our breaks, please feel free to, or please visit the exhibits. There will also be a welcome reception tonight, starting at 6 o'clock. That's also going to be held in the exhibit hall. Tomorrow morning, we're having a hands-on urodynamics course. If you didn't register for this, then please check at the desk and make sure that there's room, because there is limited space. But it's a hands-on urodynamic course from 7:15 to 8:15, and that's going to be in the Deer Valley room, also here on the second floor. Reminding you that this is a CME accredited event. In the packet that you received is a form that needs to be completed, and then you'll receive an online survey in order to claim the CME credit. And we have gone to a lot of trouble to make sure all the talks and speakers have followed CME guidelines. The disclosures for the speakers are listed in your handouts in the course brochure, and where they're relevant, they're mentioned again during talks. Any speakers that haven't already loaded their slides for today, please visit our friends AV team in the back. I'd like to mention, as Sharif said, in August 28th to 31st is this year's ICS International Scientific Meeting. It's going to be held in Philadelphia. It's the first time that the ICS meeting has been in the United States since 2009, San Francisco, and we have the co-hosts, Alan Wien and Diane Newman here. It's going to be an outstanding meeting. If you're not currently an ICS member, please consider joining. Visit our website, ics.org/join. If you have cell phones, please turn them on silent or vibrate. And we're going to also mention that all the talks today are being recorded. So when we come to Q&A sessions, I'll typically start with a few questions for the panel while we wait for anyone who has questions or difficult cases they want to present, but we're going to ask everyone to come to the central microphone and make sure you state your name, where you're from, so that we can, first of all, have good quality recording, and secondly, make sure that everybody in the room understands the question and is able to participate in the discussion. Thank you very much. Have my first slide. So I think it's important to start off most functional urology talks with the basic review of lower urinary tract function and dysfunction. We want to make sure we're all talking about things the same way and that we are we're communicating and we're thinking logically. And the system that was developed by Alan Wien, the functional classification system, has really stood the test of time and is, I think, the best way to discuss things. So we're briefly going to go over lower urinary tract function, how we classify dysfunction, and how we can use this system to approach basic and complicated patients. So the first thing is we start with a simplification. We take all of lower urinary tract anatomy and divide it into bladder and outlet. Of course, for certain cases, we're going to need to be more specific, but when we're thinking about problems in general, bladder and outlet works very well. And then, so in the case of the women, everything from the bladder neck to the external urinary meatus is going to be the bladder outlet. And when we talk about function, we're only talking about two things: storing urine and emptying urine. Storing and emptying. So in order to store urine properly, I hope we all know, three things have to happen. The bladder must hold the urine at low pressure and appropriate sensation. And I think this is often glossed over a little bit. Yeah, we know it has to have low pressure, but appropriate sensation. We're really starting to appreciate sensory abnormalities of the bladder much more. This is where you would classify your bladder pain syndrome patient. They may be having appropriate pressures, but the sensation is all wrong. The outlet needs to be closed at rest and against physical stress. And there can't be abnormal or involuntary bladder contractions. So if you have a patient who has complaints having to do with storing urine, they have to have one of these abnormalities. And similarly, three things have to happen in order for the bladder to empty properly. First, a coordinated bladder contraction of adequate magnitude and duration. Second, simultaneous, coordinated relaxation of the bladder outlet. These are not two things that happen separately, but they happen together. The bladder outlet actively opens. When you do video urodynamics of a woman voiding, you see the bladder neck goes from completely closed to wide open in a big funnel. And there's no fixed anatomic obstruction. So similarly, if you have a patient who is not emptying or is complaining about not being able to empty, you've got to have a problem in one of these three areas. So that leads us to a classification system, which is very simple. Failure to empty and or failure to store, and because of the bladder or because of the outlet. So to a first approximation, every single patient we see with a lower urinary tract problem fits onto this little grid. Failure to empty, failure to store, because of the bladder, because of the outlet. This should describe every patient. When they have a failure to empty, we're calling that urinary retention. And if it's because of the bladder, we think about physiology like classic diabetic cystopathy. We think about a destructive sacral injury. These are things that would cause failure to empty because of the bladder. Because of the outlet, of course, the classic thing in urology is the man with benign prostatic obstruction. But for this group, let's think about the people that we got a hold of and did a sling, and now they're obstructed, so post-sling. If the patient has a failure to store, we're calling that incontinence. If it's because of the bladder, we're in the overactive bladder, urinary urgency incontinence. If it's because of the outlet, we're calling that stress urinary incontinence. So we see how this system, very simple, and each square in the diagram, each square will track to a list of causes and a list of treatments. So for maybe you've got a new nurse, a new resident, they're confused, they can go right to a textbook. What are the causes of this? What are the treatments? And so we can use this to talk to our patients. We interview them, we create a working diagnosis. From that diagnosis, where they are, we define the treatment options. We discuss with the patient what their priorities are, what their goals are, and then we decide on going right ahead with treatment or additional testing if that's indicated. So let's take an example. The working diagnosis is female stress incontinence. We've gone through, we've interviewed them, they've only got that one box. Failure to store because of the outlet. That's what we think it is. We define the treatment options. If we didn't know, we can look it up. We can observe stress incontinence. We can use pelvic floor muscle training. We can use one of the vaginal devices. We could use meds, although there's no FDA-approved meds in this country. We can do bulking agents. We can do surgery. Those are the treatment options. Then we talk to the patient, and we define what that patient's goals are. Let's say the patient says, I do ballroom dancing twice a week. My goal is to be able to do that, wear nothing more than a liner, and be secure. That's how dry I need to be. We might make a different treatment decision for that patient than we would if the patient is a 35-year-old high-impact aerobics instructor and says, I don't ever want to leak a drop ever under any circumstances. So, we would direct our decision-making like that. And then we would decide on treatment versus additional testing. In the first case, we might say, well, you might want to just try one of the vaginal support devices to use for your 2 sessions of ballroom dancing every week, and the rest of the week you're not bothered. We wouldn't need to do any testing. Whereas that other patient who might need a tight sling to be as dry as she wants to be, we'd certainly do a stress test, and we might do full urodynamics, depending on other criteria. So this is a very useful approach and construct. And it would be really great if it were as simple as I just outlined it. But unfortunately, it really rarely is that simple. There is no reason, unfortunately, that a patient is limited to one problem. And we can pretty easily come up with patients that have problems in all 4 categories. And we can even have patients that have more than one problem in an individual box. So a moderately complex patient is someone with mixed incontinence. They have both failure to store because of the bladder and because of the outlet. Or we could have a 40-year-old woman who we did a sling on because she only had stress incontinence with minimal urgency. Now her urge is worse and she's got a cystocele. All of a sudden, if we interview her, there could be a couple of different things going on there. Or an 80-year-old woman who comes in with no prior history and says, I have urgency incontinence, but I'm also having trouble emptying my bladder. So we've got diametrically opposite symptoms. And how do we start thinking through these more complicated patients? And again, I think that this construct is still very useful. And here's the example of someone that's got all the boxes checked. 63-year-old female, mixed incontinence, and when you ask her, both types of incontinence seem like they're clinically relevant. But she's also had type 2 diabetes for 20 years, and she's got peripheral neuropathy. She had 2 prior operations, pelvic operations, can't tell you exactly what they were. She's got a cystocele outside the introitus, a well-supported bladder neck, but when you examine her, she still has drops of stress incontinence and a cath residual of 180. So how the heck do you approach that? And I think that's why we're here today. You know, we're all pretty good at those basic things, but now we've got really complicated patients that we see in our practice every day. How do we start taking care of that? And I'll throw out some clues that we can be thinking about as we approach different patients here. When you read the books, they always say, well, ask the patient which problem has the greatest effect on the quality of life. I think it's relevant to know that, but I don't usually find that to be all that helpful. I certainly want to make sure I've addressed that with the patient, but that isn't necessarily the best place to start. One thing to start is, what's the easiest to treat? Is there something I can do quickly, easily, low risk that will help this patient? Is there a curable problem? So when you have a complex patient with many things, is there one thing I can completely take off the table? And, you know, we think about stress incontinence and prolapse, at least at times in the complicated patient, getting rid of a big problem as a way to really move things along. Another example, which doesn't exactly fit into this functional classification system, is if you have a patient with recurrent urinary tract infections going on at the same time as a bunch of other complaints. One of the first things I'll do is say, for the next 3 months, I'm going to put you on a once-a-day antibiotic to take that off the table. We're going to eliminate one part of your problem and see if we can move forward there. If there's a correctable problem that causes more than one symptom, and of course we've always dealt with this in urology for BPH, benign prostatic obstruction, can cause both the obstruction and the urge symptoms. Can we figure out in which case we can do one thing that'll get rid of both problems? Similar, as we mentioned earlier, about mixed urinary incontinence. Or a treatment that can improve more than one symptom. And there are many of those, but, you know, of course, pelvic floor muscle training is something that can improve symptoms in many of these areas. So just looking at the greatest impact on quality of life isn't always the easiest, the best way to approach it. So to review the curriculum, what we have coming up today, the morning on female urinary incontinence and overactive bladder. In the afternoon, a female pelvic medicine potpourri and a focus on improving urodynamic practice. Tomorrow, morning on neurogenic lower urinary tract disorders, practical anatomy, pelvic organ prolapse, urethral disorders. And I think you will agree that I have arranged for some excellent Sherpas to help carry us up the mountain and solve the problems that we're faced with. I'd like to introduce them. Alan Wien, we should just say Urology Hall of Fame. It'd be a lot easier than listing accomplishments, but he is the Founders Professor at University of Pennsylvania, was chairman there essentially forever, I think, until this year. He remains the residency program director, the editor of Campbell's Urology, and important for this talk, one of the directors of the International Consultation on Incontinence. And we just had the most recent book published, and Alan will be bringing some of the algorithms from that book. He's a teacher, researcher, and writer extraordinaire. And Alan, along with Diane Newman, will be co-hosting the ICS in 2018 when we're in Philadelphia. Diane, the leading urologic nurse in the United States, the co-director of the Penn Continence Center, prolific researcher and author, member of the very first United States guideline panel for urinary incontinence. You've already briefly met Sharif. Sharif is professor of urology in Cairo. He is our general secretary of the ICS. He's the founder of the Pan-Arab Continence Society. He's also an outstanding author and editor. But one thing you'll miss from Sharif in this course is he is an absolute expert at teaching surgery. And if you can imagine the world that he lives in Cairo, taking care of the spectrum of disorders, if you have any incredibly difficult surgical problems, I would seek out Sharif on the side, because he definitely is a man who can approach very difficult surgical problems. And similar to that is Holly Richter in the back, the J. Marion Sims Professor of OBGYN at University of Alabama. And I read that UAB was the very first United States Center of Excellence in Continence Care recognized by an AFC, and I'm sure that has a lot to do with Holly's work. She's an academic, intellectual leader in our big National Institute of Health sponsored research consortiums, the Pelvic Floor Dysfunctions Network and the Urinary Incontinence Treatment Network. And I'm really happy as chair of the Worldwide Fistula Fund to say that we've recruited Holly to join our board because she has a long history of working overseas to take care of women with childbirth injuries. Mike Kennelly was actually the first person I approached. I really wanted Mike to be on this panel. He has a unique background. I mean, really in urology, to have excellence in female reconstructive surgery and in neurogenic bladder and taking care of neurogenic patients is a terrific adjunct. And again, when you have crazy things, Mike is a good resource because he's seen a lot of crazy things over the years. Dr. Jeanette Potts, another unique person in American urology, trained and board certified in family medicine, and then after that went to do a urology fellowship at Cleveland Clinic where she worked on the urology faculty for 15 years. She's made seminal contributions to our field in urogenital infections, pelvic pain, and in prostate cancer screening, being one of the first people to really advocate for active surveillance. She's a worldwide lecturer and patient advocate extraordinaire. And Vanny Dandaloo, who will be the scientific program chair for the ICS when it comes to Las Vegas in 2020. She has been the chair of OBGYN and the residency program director at University of Nevada until this year. She's now the medical director of OBGYN at Optum Women's Health in Las Vegas. She has won national teaching awards and has research interest in trends in use of surgery, cost analysis for GYN treatments, and surgical skills training. And that's the end of my little introduction for Arizona. And we'll move on to the next speaker, which is Holly Richter.